Okay, great. So we'll get started. We're going to begin by reviewing just a couple of very basic definitions. What do we mean by high-risk lesion? What do we mean by upgrade? And what is an incidental finding? Because these definitions really play into how we've decided to manage each of these entities. And we're going to speak about ADH, flat epithelial atypia, LCIS, radial scars, and papilloma. So high-risk lesions include those that are premalignant or precursor lesions, meaning that if you were to leave them in the breast, at some point in the future, they can turn into a invasive or in situ breast cancer. They can be those that are associated with upgrade at the time of surgical excision, and often they confer an elevated risk of developing breast cancer. When we say upgrade, what are we talking about? So at the time of a percutaneous biopsy, you get a high-risk lesion, and then when you recommend surgical excision, then you find cancer. And this has to do with histologic underestimation. When you're taking a biopsy sample, you're only taking samples of a representative area. And in terms of for the pathologist, they really lack the context of the surrounding breast tissue. Now, we're going to hear the term incidental finding a lot. What do we mean by that? So an incidental finding when you do a biopsy is when the pathology that you get really has nothing to do with the area that you targeted. So for example, you see indeterminate calcifications, you do a stereo, you do sample those calcifications, but those calcifications were in benign epithelium. But in the uncalcified tissue, you happen to get a high-risk lesion or a cancer. So really, that cancer or high-risk lesion was completely incidental to your initial target. When we say incidental finding at the time of surgical excision, you get a high-risk lesion, you recommend excision, and then there is an upgrade. You do find cancer in the surgical specimen, but the cancer that was found is away from the biopsy site changes and the area where you took the samples from. So again, it is an upgrade, but at the same time, that cancer is considered an incidental upgrade. This is a study that was published several years ago. It surveyed about 40 different breast academic institutions in the United States, and it asked a couple of questions. When a core biopsy reveals X, what is your typical management recommendation? And the follow-up question was, do your breast imaging colleagues at your institution make the same recommendation? And if you look at the results, it really depends on the pathology. So in some cases, we are very, very uniform. So for example, ADH and papilloma with atypia, in those cases, 95% of those surveyed do recommend an excision. For the other high-risk lesions, it's much more variable. The blue is the area that's recommended for surgical excision, and you can see there's a lot less consistency. In addition, in terms of that second question, do your colleagues make the same recommendation? At about 10% of institutions, the recommendation is going to change dependent on the radiologist who did the biopsy. So there's still, even after all these years, a lot of inconsistencies, both among practices throughout the United States. And I think one of the goals of this talk is to kind of review some of the data, and I'll talk about what we do at Memorial and why we do that, or the data supporting our practice. So beginning with ADH, atypical ductal hyperplasia is the most common of the high-risk lesions that we get. It's distinguished from DCIS based on architectural complexity and extent. And at the time of a core biopsy, you get very limited material, and it's not always possible to quantitate the criteria for distinguishing ADH from low-grade DCIS. And most of the rules that were made in how to distinguish ADH from DCIS were based on examination of excisional biopsy specimens. So because of that, it's not really surprising that about 30% of cases of ADH are upgraded at the time of excision. It is considered a non-obligatory precursor to DCIS or invasive cancer, meaning that if you were to leave it in the breast, in some women, eventually it's going to turn into a cancer. In some women, it may stay as ADH. And we have no reliable mechanism at this point to know who it's going to progress in and who it's not. Adriana Corbin was a pathologist that was at Memorial, several years ago. This is the way she kind of explained it to me, and it made it easier for me to understand why it's so difficult to, why there's so much variability between ADH and DCIS. This is a normal terminal duct lobular unit, a normal TDLU, and you have a duct and a lobule with acini. On the close-up image, you can see that at the periphery, you've got these cells with a clear halo around them. Those are the myoepithelial cells. But towards the center, you've got these inner cells that have the darker lines. Those are the ones that are going to turn into either flat epithelial atypia, ADH, or DCIS. So usual ductal hyperplasia is benign, and the way she explained it to me is instead of having that nice single layer of cells, all of a sudden with usual ductal hyperplasia, you kind of have a pile of rocks jumbled on top of each other. Okay, but this is completely benign. When the pathologists start talking about atypical ductal hyperplasia, you start to have a little bit more organization. So instead of that pile of rocks, all of a sudden you're forming small arches, a little bit more structure or rigidity. Now, the next level would be low-grade DCIS. Then all of a sudden, you're talking about busier. Instead of one arch, you have a lot of arches. And she said, think of it not as being a single arch, but as like a coliseum. So it's really that spectrum that the pathologist is looking for in the samples when they're trying to distinguish between ADH and low-grade DCIS. In terms of imaging, what do we see? There's really no specific imaging features for ADH. Often we get it when we recommend biopsy of calcifications, more commonly amorphous calcifications, and on MR, it's more likely to be non-mass compared to mass enhancement. Here's an example of a woman. She does have mammographically dense breasts, and on the magnification views, you can see that there's a group of amorphous calcifications. When those underwent biopsy, that was ADH. She has another group of calcifications more infromedially, morphologically similar, but when those underwent biopsy, that was benign. And when this ADH went to surgery, it was not upgraded. Another case where, again, we see indeterminate calcifications. These underwent biopsy and were ADH, but in this case, this was upgraded to DCIS at the time of surgical excision. And again, there's no way to predict which time those calcifications, they all are amorphous, they all look very similar. Sometimes they're going to be benign, sometimes they're going to be ADH, sometimes they're going to be ADH upgraded at the time of excision. On MRI, more typically, we see non-mass enhancement. These are subtraction MIP views of the left and right breast. In the retroareolar right breast or the central right breast, you can see that there's an area of asymmetric non-mass enhancement. It does show benign kinetics, not uncommon for non-mass enhancement. And when this underwent biopsy, this was ADH, not upgraded. Fortunately, with ADH, because of the upgrade rate being very high, 20 to 30%, in that survey, we saw that 95% of those surveyed do recommend excision. So we are very, very consistent about that. So I think the more interesting question is, if there's a very small area of ADH, can we observe those patients instead of recommending surgical excision? This was something we looked at our institution. We had about 200 cases of pure ADH. About half of them were defined as focal, and focal meant one focus less than 2 millimeters in size. So a very, very small area of ADH. Can you follow those patients instead of recommending excision? Although our numbers were small, the answer was no. The upgrade rate was about 7%. So because of this, at our institution, even if there's very, very focal, small areas of ADH, we continue to recommend excision. In the same study, for non-focal ADH, the upgrade rate was about a little greater than 20%. So what are the take-home points for ADH? No specific imaging features. I think more commonly we get it with calcifications, but nothing about those calcifications will make you predict that you're going to get ADH. No subgroup that can be safely followed. So whenever you get ADH, again, it's very good that 95% of radiologists will recommend excision. One caveat, the American Society of Breast Surgeons does say that if you have a very small area of ADH and your pathologist says it's been completely excised, then maybe in those cases, if you talk to other members of the multidisciplinary team, maybe it would be okay to follow those. But I think in general, we always recommend excision for ADH. Moving on to flat epithelial atypia. It's defined as cytologic atypia without architectural atypia. And that's what kind of distinguishes it from ADH and DCIS. ADH and DCIS, you have both cytologic and architectural atypia. Flat epithelial atypia has been called various names in the past. You might have heard it as being called clinging carcinoma in situ or columnar cell change with atypia. That is all the same entity as FEA. And again, just like with ADH, no specific imaging feature. A lot of times we'll get it when we're biopsying calcifications. The overall rate of upgrade for FEA is around 10-11%. Women who have other risk factors tend to be more likely to have upgrade. This is a table that summarizes some of the papers that are available describing the upgrade rate. Again, you can see that the upgrade rate is very, very variable from as low as 1% all the way up to 36%. But I think one of the things you need to look at is when you read these papers, did they have rad path concordance? Anybody who does a percutaneous biopsy, we all know that once we get the biopsy results, the first thing we do is go back to our imaging to make sure that the results are concordant. If something's discordant, no matter what the pathology is, we would always recommend surgical excision. And in these papers, the ones that had the highest risk of upgrade, the ones that had a greater than 25, 36% upgrade rate, in those papers, they did not have any kind of rad path correlation. And if you focus on the patients or the papers where there was that rad path correlation, then the upgrade rate is far lower. Also, in several of these papers, they specified, was the cancer that was found at the time of surgical excision, was that an incidental cancer or was that associated with the target and the biopsy site changes? And in 4 of the papers, the invasive cancer that was upgraded or found at the time of surgical excision was considered to be an upgrade. It was considered to be incidental. So we went back at our data at Memorial. We found 40 cases of FEA. It's not a common diagnosis. A lot of times you'll have FEA mixed with another high-risk lesion, and you can't include those samples if you're looking to look at the upgrade rate of FEA. It's got to be pure FEA. So we only had 40 cases, but among those, the upgrade was 5%, so 2 out of the 40. When we looked more carefully at the cancers that were found at the upgrade, they were all very, very small cancers, 1 to 2 millimeters in size, low-grade invasive cancers. And in both of those samples, the cancer was not associated with the biopsy site changes. So it was in the surgical specimen, but away from the area that underwent biopsy leading to the excision. So these were considered incidental early cancers. So what are the current recommendations? Well, according to that survey, FEA is recommended for excision at about 75% of academic institutions. The American Society of Breast Surgeons actually recommends no excision of pure FEA. The NCCN comes a little bit softer, saying it may not require excision. It doesn't say not to excise it, but says it might not be necessary. At Memorial, we stopped excising FEA several years ago. The one caveat is if the patient has a personal history of breast cancer, then we still do technically recommend excision. And the only reason we have that caveat is in those 40 patients that we retrospectively reviewed at our institution, none of them had a personal history of breast cancer. So because we don't have data specific on that population, if somebody's had a personal history, then and they get FEA on a biopsy, we still do recommend excision. Some of our surgeons actually don't necessarily follow that because the data is so small, the numbers are so small, but that's our technical official recommendation. Lobular neoplasia. I think we all can appreciate that lobular neoplasia is a spectrum of disease. It's considered ALH when cells do not fill or distend 50% of the lobular acinine. If it's more than 50%, it's called LCIS, so it is really a spectrum. It's considered a marker of bilateral increased cancer risk. The cancer can be in the same breast. It can be in the contralateral breast. Often that cancer does not develop until more than 10 years after the initial diagnosis of LCIS. Both are associated with an increased relative and lifetime risk of breast cancer, a stronger association with LCIS compared to ALH. Just like ADH and FEA, there's really no specific imaging features of lobular neoplasia, usually an incidental finding, often when we biopsy calcifications. When you look at the upgrade rate, again, it varies highly in the literature, 0% all the way up to 35%. But we have to do rad path correlation. And in the papers where they do specify they did do rad path correlation, the upgrade rate is much lower at about 0 to 3%. And for these reasons, we stopped excising lobular neoplasia, LCIS, at Memorial probably 7 or 8 years ago, and we've kept to that policy since then. Of course, that's only for classic LCIS. If you have non-classical LCIS, any kind of a variant, pleomorphic LCIS, florid LCIS, LCIS with central necrosis, in those cases, we always recommend surgical excision. They're more likely to be upgraded at about 40%, more frequently associated with an invasive cancer. So the non-excision is only for the classic LCIS. This is an example of a woman who had, suspicious calcifications. Those underwent biopsy. Those were pleomorphic LCIS. In this case, there was no excision, no upgrade at the time of excision. A different patient where she had suspicious non-mass enhancement on MR. This underwent MR biopsy, again, was pleomorphic LCIS, but at the time of excision, went up to invasive lobular cancer. But again, there's not really anything specific that's going to predict an upgrade. How do we perform across the country? Again, the data is kind of a little bit variable. 70% of institutions still recommend excision of LCIS, 60% for ALH. I think that number has slowly over time been getting smaller and smaller as more places are no longer recommending excision. Again, at our institution, classic lobular neoplasia is not excised unless there's rad path discordance, unless it's a variant of LCIS. Radial sclerosing lesions. So all the lesions we've talked about so far are those high-risk lesions that really have no specific imaging features. So radial sclerosing lesion is when we start getting into those where they do have a imaging appearance suggestive of the diagnosis. So radial sclerosing lesions include both radial scars and complex sclerosing lesions associated with an increased relative and lifetime risk of breast cancer. Radial scars on pathology, they have a concentric architecture with a central hyalinoid nidus and those radiating arms that form that distortion that we often see on imaging. In comparison, a complex sclerosing lesions are more ill-defined, so they lack that centralized nidus. In the past, they used to say radial scars are less than a centimeter in size. If they're bigger than a centimeter, then we would call them complex sclerosing lesions. I think that's changing a little bit with the pathologists. They say it's not really about size, but they really have different patterns that they're seeing on histology. And so with complex sclerosing lesions, you don't have the central nidus, you have just more irregularity in that area. Complex sclerosing lesions, we still do recommend surgical excision for. The question is, do we need to excise all radial scars? Radial scars are commonly imaging occult. We see them about 1 to 2% of percutaneous biopsies, but when you do autopsy series, you find far more of them, about 28%. Again, do have an imaging appearance suggestive of the diagnosis. Often you see distortions or spiculations without a central mass. You have a radiolucent center. That's only on mammography. On ultrasound and MRI, radial scars are essentially indistinguishable from your typical breast cancer. So on ultrasound, an irregular or angular mass, often same thing on MR, you're going to see a suspicious mass enhancement. This is kind of what we see on imaging on a mammogram. Again, that distortion, but then you have a radiolucent center. Because we're doing more and more tomo, we're finding more of these radial scars. So this was a paper that was published a couple of years ago, and it showed that when you do 2D full field digital mammogram and you biopsy areas of distortion, when we did, in the pre-tomo years, radial scars made up about 10% of distortions that were biopsied. Now, as we're finding more and more areas of architectural distortion because of tomo, that number has changed. So in the past, it was 75% cancer, about 10% radial scars. Now with with distortion found on a tomo, instead of 75%, about 50% of distortions we see on tomo turn out to be positive for cancer. And instead of 10% being radial scars, this number has gone up to about 33%. So again, more of these distortions we're finding on tomo that we never saw on a regular 2D FFDM are going to turn out to be these benign radial scars. Do we need to excise radial scars? This was a study, it was a systematic review that included about 3,000 excised radial scars in 50 different studies. Part of the inclusion requirements of this meta-analysis was that they had to have information on the biopsy gauge of the needle used to do the percutaneous biopsy, as well as the rate of upgrade. And any study that did not include that very critical RAD path concordance was not included in this study. So using that exclusionary criteria, the overall upgrade was 7%. Then they divided it into radial scars with atypia and radial scars without atypia. So they had 2,000 radial scars without associated atypia. And for those radial scars diagnosed with a vacuum-assisted biopsy between 8 to 11 gauge, the upgrade rate was only 1%. And again, most of these are from distortions that we see mammographically. We do those using a 9-gauge stereo vacuum-assisted biopsy, so it really does fall into that category, and the upgrade rate is very low at 1%. What about if there is associated atypia? So there are about 300 cases of radial scars with associated atypia, and not surprisingly, much higher upgrade rate. The upgrade rate was about 20%. So radial scar with atypia, you excise. Radial scar without atypia, we don't. Same thing, we looked at our data at our institution just to make sure that we found the same results, 130 radial scars, and the overall upgrade rate was only about 1%. So again, radial scar without atypia, if there's RAD path concordance, no excision, routine imaging recommended. If there is radial scar with atypia, if you have a complex sclerosing lesion, so those larger ones with motor disorganization, then, or of course, if there's any case of RAD path discordance, we do recommend surgical excision. How does that compare to what is being practiced around the country? According to that survey, at most centers, at about 75%, excision is still being recommended for radial scars and complex sclerosing lesions. So unfortunately, those two categories were merged together in that survey. And you do wonder that if they separated radial scars and complex sclerosing lesions to do two different questions, how would that impact those numbers? Finally, intraductal papilloma. We know that papillomas are associated with an increased risk of developing subsequent cancer. Just like with radial scars, they do have a imaging features suggestive of their diagnosis. Often mammographically, you'll see an enlarging mammographic mass. This was an example where in ultrasound, there were two masses. One was associated with a dilated duct, you can see in the lower right-hand picture. Sometimes you see a complex cystic and solid mass where you have a solid component and you've got that bulging contour, which distinguishes this from a benign acorn cyst. What do we see on MRI? On MRI, we often see one or multiple masses in a ductal distribution. They're often relatively small, less than a centimeter in size. A lot of times they do demonstrate washout kinetics. And sometimes you can also see a dilated duct on the T2 weighted sequences. And if you see that constellation or that combination of findings, that is most suggestive of a papilloma. What are the upgrade rates? This was data from our institution. Again, separated between papillomas with atypia and papillomas with no atypia. If there's associated atypia, the upgrade rate was very high at about 20%. But if there was no upgrade rate, it was less than 1%. This table summarizes the findings of various studies where they looked at benign papillomas found on core biopsies that were also rad path concordant. So these studies all have rad path concordance. Anything discordant was not included. And the upgrade rate rated from about 0 to about 7%. Most of the upgrades were to DCIS, very few invasive cancers. This was a more recent study. This was a multi-institutional study that also, wanted to know the same question. It was a prospective study which looked at patients who had a benign papilloma at the time of percutaneous biopsies, and then they consented to excision. Any discordant cases were excluded. There was centralized pathologic review where all the samples were sent to a central place and reviewed by the same pathologist. And what did they find? The upgrade rate was about 2%. There was one patient who had low-grade DCIS, another ADH bordering on low-grade DCIS. So that was the read at the local institution. When they went to the central review, they found actually no cases of upgrade. So one of the cases that they said would have been an upgrade, when it was reviewed by central pathologists, they said there's no findings of DCIS. In the second case, again, they also found no findings of an upgrade, but the one caveat was for some reason they were missing some of the slides. So conceivably, there could have been an upgrade in one of the slides that weren't sent in for that central review. So in worst case scenario, it would have been a 1% upgrade rate. So same thing, we stopped excising papilloma many, many years ago. Papillomas do have a relatively suggestive imaging appearance. These small masses, may be associated with the dilated duct. We only excise it if there is atypia associated with it, if there's rad path discordance, or if the patient's symptomatic. So if they have suspicious nipple discharge, we do a biopsy and we find a papilloma. In those cases, the surgeons will go ahead and excise it. This is a slide just summarizing kind of what we discussed in terms of whether excision is recommended. I included, the data from our institution in the areas that we had them, which kind of helped help us decide how we wanted to manage these. Again, it is clearly variable throughout the United States, but that's kind of how we decided that we wanted to practice. So just in summary, wide variation on the management of high-risk lesions. I think it's important to look at your individual institution data. But, just a caveat, this whole idea of rad path discordance, that this is, assessing rad path concordance is so critical. It's a critical part of doing percutaneous biopsies. And, any paper that you read, you really want to make sure that's a part of the decision-making process before changing your practice based on that. And that's about it. Thank you.